So we're going to move on to Dr. Margolin, who's going to give us the other view of cancer care as the advances in systemic therapy. So thanks, Kim.
Well, thank you for letting me invite myself or something like that. And Laura, I didn't, if the naval surgery thing doesn't work out, stand-up comedy could be your next shtick. All right. I don't think I'm going to be walking around because I need my cheater screen. And all right. Well, thank you. I hope you enjoy this, and I'll try not to use too many really massive words, but if I do, you can ask me later. So actually, the title of the talk was something about treatment of advances in advanced melanoma, but I'm going to sneak in a few slides about adjuvant therapy of melanoma, because that's important, and it's an important part of what we do and what many of you or your loved ones or your friends have experienced. So there might be an exam, we'll have to see. The word adjuvant, you may have heard, especially those of you who've had adjuvant therapy, but there's a couple of meanings that are totally different from each other and that I use all the time, every day. The first one is what you guys are probably most familiar with, which is the treatment that we give you usually following surgery. And incidentally, I have the privilege of working both with Dr. Essner and Dr. Trevin Fisher, who's in the back somewhere, and Dr. Foshag as well. And before I came to St. John's, I had never had such a close working relationship with the surgical oncologists, although they were good at my other institutions. So this has been a lot of fun and a lot of very close teamwork. And then Melody, whom you just saw. So adjuvant therapy is what we give you generally after surgery if it's felt that the risk of melanoma returning is high enough to warrant an interventions like the adjuvant therapy, which I'll talk about in more detail in a minute. And then parenthetically, the term neoadjuvant is essentially a made-up word, but neoadjuvant means treatment like that, adjuvant meaning something that helps something else, and neoadjuvant meaning the kind that we do before surgery. We'll get back to that and why we do it and what that means, and what the benefits might or might not be. So the other meaning of adjuvant is the stuff that the scientists use to make vaccines work. Vaccines are usually made from little bits of what we call antigens, something that the immune system has to learn to recognize and will hopefully either prevent an illness, such as the vaccines we get against the flu and COVID and so forth, or in the case of cancer, more often the research is happening on trying to make cancer go away once the cancer's been diagnosed, because for about 100 reasons, it hasn't made sense nor has been successful to make preventive vaccines other than for cervical cancer against human papillomavirus. So back to the title, Advances in Adjuvant Therapy in Advanced Melanoma. We've really seen leaps and bounds over what I would say was approximately 17 or so years, 2005 or so, representing when we first got to test the drugs that we now use on a routine daily basis, which are called the immune checkpoint blocking antibodies. And I may call them different things throughout the talk. It was somewhat after that we also got our hands on access to targeted therapies, which are oral agents that I'll talk about in a few minutes. And so our armamentarium, although still quite limited against advanced melanomas, is a whole lot better than it used to be when I started being attracted towards being a melanoma doctor. So again, back to adjuvant therapy. We used to have interferon, which was horrible. It did very little, had very little benefit, and it had a lot of side effects. And the side effects, unlike the drugs we have now, were not kind of idiosyncratic where they only happen to certain people and not to others. The side effects happened to everybody. Moving on, we were able to get these immune checkpoint blocking antibodies, and then they have moved into earlier stages of melanoma as we learn how to give these drugs more safely and more effectively, which is, double benefit. And I'll show you some graphs of that towards the end of the talk. This concept of neoadjuvant therapy, which is given before the surgical resection, but of course after a diagnostic biopsy, because we can't start treatment with somebody who doesn't have a diagnosis, we've seen with both the immunotherapies and with the targeted agents a very high response rate. And the other benefit is that both at the time of that initial biopsy as well as at the time of surgery, it allows tissue acquisition for either investigation in the lab or in the future when we have biomarkers that'll help us to distinguish patients on what kind of therapy they should get. Unlike the current situation where Dr. Hugh and Dr. Batra and all of their colleagues in dermatology usually make the first diagnosis with a shaved biopsy, and it's usually a very small amount of tissue. Going to a dermatopathology office, the surgeons, when they do that wide local excision that Dr. Fluke just told you about, usually don't actually find any residual melanoma there, but when they do, it's very little. So we don't get much information, even if we try to study the characteristics of that initial biopsy. But if we talk about neoadjuvant therapy, we're often treating a very large, bulky, single-site tumor, most often a cluster of lymph nodes, for example, in the axilla or in the groin or maybe internally. And so we can get a substantial amount of tissue before any intervention. And then after the intervention, when the patient goes to the operating room, we can also get a pretty good sized chunk of tissue for study. So the other things that are provided with neoadjuvant therapy include potential for reassurance to both doctors and patients that the treatment is working, or an early sign that the treatment isn't working and therefore surgery should be scheduled sooner. It's already been shown from a number of studies, although the numbers are still somewhat limited, that we are not risking a significant negative impact on surgery by doing neoadjuvant therapy. In other words, we can see if the tumor's growing, and give or take a little bit of time, because you're going to see that immunotherapy can be fairly slow in acting. But once we're sure that the tumor is growing, if the patient has not been fortunate enough to have a good response, the mass can be resected, and we're not really losing any time. So I just mentioned at the bottom and in the picture that the concept of neoadjuvant therapy seems rather different than treating advanced disease, but you got to be very careful how you look at the statistics and what types of tumors people have, and try to avoid, the concept of apples or oranges, or maybe more like green apples versus red apples, as in this picture. So you may not think you need to know about mutations, but you kind of do, because it may come up in your journey that we need to know whether your tumor, whether your melanoma has the most common mutation, the BRAF V600 mutation, which has a drugability associated with it, or whether there are other mutations that may influence the behavior of tumors that have or don't have a BRAF mutation. And then I'll tell you about neoantigens. So a driver mutation, I think that Dr. Miles Picus told us earlier about what drivers are and what oncogenes are. There are suppressor oncogenes, and there are sort of activating oncogenic oncogenes, such as the BRCA. Well, no, that's a suppressor as well. Sorry, my bad. But the BRAF mutation, which occurs in about half of melanomas in Caucasian individuals with melanomas other than the acral melanomas or the internal mucosal melanomas or the melanomas growing in the eye. And that's druggable with a couple of drugs that we use fairly often now. But it is neither necessary nor sufficient. Not necessary because you can have, as I said, half the patients have their melanomas without that mutation. And it's not sufficient because we know that it can be found in moles, but those moles are not all going on to develop melanoma. The site where the mutation occurs confers this activation on a specific protein that hastens the speed at which melanoma cells turn over and activates other pathways in the cell that give rise to its behavior. Passenger mutations are those that influence, I already said, the behavior of either a driver or a melanoma that doesn't have a driver, and they include the CDKN2A, which you saw was also one of the germline mutations that people can be born with and have in their family as a risk factor for developing melanoma in the first place. But then it can be also acquired. Neoantigens are those antigens that the tumor is not born with, but picks up over time and probably due in part to UV or other carcinogens in the environment, and may be able to be the focus of the immune response to vaccines. And indeed, the neoantigen vaccine approach was already going on at Moderna, for example, when COVID came along, and the scientists there quickly turned their efforts from the approach that was being used to make neoantigen vaccines to neoantigen or antigen-specific COVID vaccines, such as for the spike protein. Doctors Hanjo in Japan and Allison and MD Anderson in Houston won the Nobel Prize in 2018 for medicine for the development and application of immune checkpoint blocking antibodies. Those are the ones whose names you've heard and you will hear. Jim is here, and he, I think his wife made him dress up for this. She's a scientist as well. And this is him when he's not making, record-breaking discoveries in science and oncology. He plays the harmonica, which he calls the harp, either with this group called the Checkpoints, or with a group, or with Willie Nelson, which has led to his going on tour at times with Willie Nelson. Dr. Bill Kalin also shared a Nobel Prize in 2019 for hypoxia genes in renal oncogenesis. So cancer advances really have been making history. And of course, the CRISPR that Jennifer Doudna and Emmanuel Charpentier won the prize for, I think the next year, has also been used extensively in cancer. I don't want you to try to figure out this slide. It's just to kind of remind you that we call this juncture between the T lymphocyte, the primary cell of the immune system, and either a dendritic cell, which is another important cell in the immune system, or the T cell and the cancer cell. That's called the immune synapse, the place where those things join together and usually feature many different pairs of receptor and what's called ligand. So if the receptor looks like that and ligand looks like that, one fits into the other. They're highly specific based on their sequence of their amino acids in the protein, and they exert important and very specific functions. And that's what we also know about how these checkpoint blocking antibodies work. If you want to know more, we'll have to wait till the question and answer period. So what is the benefit of immunotherapy, or adjuvant therapy in stage 3 melanoma? Everything we do and everything we think about and how we design new studies are based on graphs that look like this. And the ideal graph looks kind of like the one on the right, where you have a pretty nice separation between the curves, and they start to separate very early, and they end up with plateaus that are separate, which would suggest that what we did with whatever the therapy is might have had curative, people are surviving and are being cured more with one treatment than with either the control or with no therapy. This refers to the use of those targeted therapies in patients with stage 3 melanoma, where half the patients were randomized to get the treatment and half were randomized to get either it was observation or placebo. Sorry about that. And that was followed at 60 months or 5 years and made a substantial difference. However, as I told you, only half the patients have that mutation, and we tend to use immunotherapy more for reasons I'll get to. But interestingly, I want you to look at this part of the curve, these two curves. These two curves show that there's no separation between the immunotherapy curve and the no immunotherapy curve early on, and that reflects the fact that it takes some time for the immunotherapy to work, and also the fact that immunotherapy overall benefits a somewhat lower percentage of patients initially than the targeted drugs. But in the long run, probably more patients do well with immunotherapy and are cured. And these curves are actually progression-free or relapse-free survival curves. So these are not overall survival curves. In order to get to the long-term overall lifespan benefit, we're going to have to use a lot longer follow-up and see what happens to those curves. The benefit of adjuvant therapy in stage 2 disease is much, much lower. And as you can see that from these curves, even for the treatment group that didn't get treated, the curves do not go down as low because the stage 2 patients have a much better prognosis. We are using adjuvant therapy, so far just immunotherapy, in some high-risk stage 2 patients, which happen to be which happen to have a higher risk for relapse than some of the very low risk stage 3 patients. It's just one of the ironic things that we learn when we do staging. We need better ways of staging and a lot more molecular information, but for now, this is what we have. So stay tuned on that. Now, what about advanced disease? I'll try to pick up the pace, but I don't want to talk too fast for you not to understand me. So as I said, targeted drugs work fast and well with a 60 to 80% remission rate, but they're temporary. They don't have a cure potential. And the absolute opposite applies to immunotherapy, where the best response rates are between 40 and 55%. You'll see curves later, but they tend to be maintained. Not always, but often. The mutations and the alterations of genetic machinery that cause people to escape from the control of the targeted agents follow a very Darwinian sort of path, and then the selection of the fittest of those cells that had mutations that allow them to survive despite the targeted agents are what cause resistance. So I think I've already mentioned what's in the bottom, and I'm not going to repeat that. Sometimes we combine targeted agents in immunotherapy, and sometimes we sequence them. Treatment with immunotherapy first does not appear to reduce the chance that later on, if patients relapse, they will go on to respond to targeted therapy. That I'm talking about patients with BRAF mutated melanoma. Of course, you can't use targeted agents with those who don't have a BRAF mutation. However, treating with targeted therapy first seems to reduce the later response to immunotherapy. Now, we knew that, and that's how we proceeded with choosing treatment, but we only knew it from retroactive data review, because we tend to pick targeted therapy for patients who have very aggressive disease and need to respond right away or have a lot of disease. And we would treat with immunotherapy for those who have slow growing or a smaller amount of disease, because they can afford to wait for that response to happen. But my friend Mike Atkins and a bunch of other people got together and designed what really had to happen, and what this is the lifeblood of cancer, which is to do a prospective trial where patients are randomized to one versus the other treatment, and then finish the treatment, and at the end look back and say who did better and in what ways did they do better. So this was ultimately called the DreamSeq trial, and this trial was recently published, and it have definitively established the superiority and this is in overall survival now, for starting with immunotherapy in BRAF mutated melanoma patients. And I would like to think that so much progress is being made that this concept of having to decide about what sequence we should use will become relatively obsolete as we get better treatments. So this famous line from The Graduate, and very old movie that only some of you will remember, is that, I just want to say one word to you. And do you remember what it was? Plastics. So my word is biomarkers. We need them. We're working on them. DreamSeq's graph is here. And again, I just want to point out to you what you may have seen, that the targeted therapy first, followed by immunotherapy only if they relapse, started out with a much higher curve because it works right away. The immunotherapy first, followed by targeted therapy if they relapsed, fell down faster because of that slower time it takes and the fewer patients who benefit. But only then came out ahead with these plateaus. Now, I just want to point out, these plateaus don't necessarily mean that these patients had plateaus with what they got first or what they got second. It was whatever they got in the sequence of what they got. And it'll have to be another analysis in another paper that'll show us what the inflection point was for each of those two curves. Again, a figure that's a little complicated if you're not used to looking at figures like this. And it's just to introduce to you that we do have newer agents among these immune checkpoint blocking antibodies. The latest is actually a fixed dose combination of two drugs that Bristol Myers put together, and they were very clever. They put them together so you really can't change the dose of either one. But then we don't do that anyway. We either, if there's toxicities, which you'll hear about from Patty, we hold the dose, we treat the toxicities, and we either do or we don't resume therapy depending on how severe and how quickly reversible the toxicities were. But the Opdualag, which is named after Opdivo or nivolumab, and LAG-3, and then Dual, amazing, a drug name that actually makes sense, has proven. I'll show you a graph with that in a minute. Here's the graph, the initial graph with the Opdualag. It's not as exciting as we'd like it to be. Again, it looks like an immunotherapy graph where things fall down at the beginning, and only then do they start to even out, and there's a difference between the curves. The overall survival curve, as is often the case, didn't quite meet the statistical significance that the progression-free survival did, but it may be that over time, when those curves, if the curves stay separate, that we'll see a statistically significant survival benefit. I think this is close to my last slide. No, there's a couple more, but I'll stop soon. So where's the bar for immunotherapy in 2022? I acknowledge April Salama, one of my colleagues at Duke, for this slide that's animated. And so ipilimumab or Yervoy, low response, substantial toxicity. PD-1 blockade, that is pembrolizumab or nivolumab, both of which you're probably familiar with, substantially higher response and a much lower toxicity than ipilimumab. If you put the two together, you get a much higher response and higher toxicity. And then you add the Opdualag, and you go way down on the toxicity and almost as far up as you can go in the therapeutic efficacy. So that's really become a go-to drug for patients who don't fit into clinical trials, which should always be the first choice, and who have advanced melanoma. So I'm not going to go through that. This is what you're going to hear about from Patty. And it just so happens that when you give the best immunotherapies to patients with very small volume brain metastases of melanoma who don't require steroids and don't have symptoms that require radiation, they do just as well as patients who get those other therapies, and they do just as well as the outside of the brain metastases do. And Patty's very familiar with this curve because we started this trial when I was at City of Hope before, took it to Washington, then came back and got it into the New England Journal as the first publication. Doesn't work so well when the patients have symptoms or steroids. I'm going to skip that. And just to remind you or to tell you that we're also getting into cell therapy, T-cell therapy, for melanoma. The cells come from a tumor. They're grown in the lab. They're given sprinkles of growth factors. They're expanded. They're put in the freezer for a while until the patient needs them, and then they're given back to the patient with some chemotherapy. We won't go into why. I don't want to go too far beyond my time. And I'll stop there and say thank you very much. This slide also came from April, and some of you know that I'm really a big fan of languages. And so this was a good slide for me. So thank you very much.